So hi guys, it's Misha here. Let's talk about vasculitis. Now there are a lot of diseases when we're talking about vasculitis, and it can be actually very confusing about what you need to know and what you don't need to know. So basically, I have actually mentioned a lot of information in this presentation, and it has a lot of content, and it's because everything you need to know for your disease is basically in this presentation. These side notes that I have, if you know them point by point, you're really good for your exam or for this question basically. So when we're talking about vasculitis, what is vasculitis? Easy. Vasculitis is the inflammation of vessel wall. Most commonly, it is present within the arteries. Next, you need to know the etiology. Etiology can be either primary or secondary. It can Primary is idiopathic, secondary can be infectious or can be non-infectious. In non-infectious, it can be, for example, we can say an immune-mediated inflammation, most commonly, such as systemic lupus erythematosus. Please make this connection. Remember that in systemic lupus erythematosus, we can actually have small vessel vasculitis. Infectious can be due to, for example, direct vascular wall pathogen invasion, such as Pseudomonas, Neisseria, syphilis, can basically infect it. Great. Now, when we're talking about the treatment for most of the vasculitis is basically corticosteroids. There is an exception to this, and I will basically be mentioning it. Now, clinical manifestations is important to remember because these diseases can actually present as general symptoms like fever, malaise, weight loss, fatigue, but they can also present with eventually like organ ischemia due to luminal narrowing. Why do we have luminal narrowing? Because of the thrombus. Because what happens in inflammation? There is damaged inflamed vessels, and what does our body do? It basically does a fibrous repair of the damaged vessels, leading to narrowing of the lumen and leading to ischemia. And then we have elevated erythrocyte sedimentation rate because it's an inflammation. So you need to remember that we have an elevated C-reactive protein, which can basically lead to the RBC clumping. Great. Now, when we're talking about the types of vasculitis, like you can see in the picture, they can be classified according to the diameter of the vessels, and it can also be classified according to the properties of the vessels. For example, they can be classified into large vessel vasculitis, which are basically in the elastic arteries like the aorta and its major branches, where they can basically have a function loss and pulse weakness. Then they can be present in medium vessels such as muscular arteries supplying the organs, where we can see thrombosis and can lead to organ ischemia, infarctions, for example. And then we have small vessels such as arterioles, venules, capillaries, leading to microhemorrhage and purpura. Let's go into it. So the first one that we're talking about is basically the large vessel vasculitis. In this case, it's temporal giant cell arteritis. From the name itself, you know that it is mainly occurring within the temporal arteries that are present within the head. Okay. Now, there's a flow that you need to go through so that you can really remember each and every disease and basically say all the information because there's so much information. So, first of all, you need to remember that temporal giant cell arteritis is the most common vasculitis. Number two, you need to mention who is it common in. So is it common in females, males, older people, younger people, in children? Who is it common in? So in temporal giant cell arteritis, we know that is mainly common in people who are more than 50 years old and they mainly in females. The third thing you need to talk about is what is the definition of the disease? Okay, what is temporal giant cell arteritis? It is a chronic granulomatous inflammation of the tunica media. Okay, now for every disease, you need to start with the definition. Do not start with clinical symptoms or do not start with morphology. Tell them what it is first, okay? So that they know you have the basic information about it. So mainly it is present in temporal arteries, but it can also be present in vertebral arteries, ophthalmic arteries, or within the aorta. Treatment is corticosteroids. In the biopsy, so whenever we're talking about, these kind of diseases, we mainly talk about like biopsy because to give the definitive diagnosis for these kind of inflammations, we have to do biopsy. Now, in this case, the biopsy, we can see segmental granulomatous vasculitis. We can see multinuclear giant cells. And now the thing is that if, for example, you do a biopsy and you get a negative result, It is not necessary the patient does not have temporal giant cell arteritis. It can just mean that the particular segment that was taken for the biopsy did not actually have that, we can say, that inflammation in that particular segment, right? So that can, or it is the unaffected segment that was chosen. Now, the second thing that we can see is that there is segmented internal elastic lamina. So it's segmented internal elastic lamina, and it is due to the destruction. The third thing is intimal fibrosis. So we can see that there is lumen narrowing. Now, what can we see macroscopically? If a patient comes to you with a very thick temporal artery and it is very tender and it has nodules and it is very stiff, for example, this can be a sign, or rigid, for example, this can be a sign of temporal giant cell arteritis. If the ophthalmic artery is involved, the patient can also present with some visual impairments, right? So let's talk about some of the clinical features. Headaches due to temporal artery, visual disturbances due to ophthalmic artery, jaw claudications if the mastication vessels are involved, flu-like symptoms because they can present general symptoms as well, palpation, pain. So when I palpate, that's why we say that it is tender. And next, what we can see is that they also have an elevated ESR, as I have already explained this. Now, we can talk about the next disease, which is Takayasu's arteritis or pulseless disease. You need to understand why it's called pulseless disease, because if you just say pulseless disease, they will definitely ask you, why do we call it pulseless? So who is it common in? Asian females who are less than 50 years old. What is the definition of the disease? It's a chronic granulomatous inflammation of the aorta and its major branches. What is the morphology and the clinical features that we can see? So because it is affecting the aortic arch and its main branches, what do you expect? For example, it's affecting the subclavian artery or the brachiocephalic artery. We can, as I mentioned, that obviously if there's inflammation, there will be healing, there will be stenosis, there will be hypotension of the upper limbs. And what do we see? There's no pulse in these patients, right? Because the blood or the vessels which are supplying the upper limbs are actually having stenosis. So we have hypotension. So we cannot actually feel the pulse in these patients. Okay. The next thing that we need to also talk about is that they can also have neurological symptoms, which is very logical because we didn't say that only subclavian artery is affected. We're talking about brachiocephalic artery. We're talking about all the branches of the aorta, which means that the brain can also be involved, and this can lead to neurological symptoms as well. Now, so we're talking about Takayasu. Now let's talk about biopsy. What do we see in the biopsy? We can see that there can be irregular fibrous thickening of the aortic arch because of the intimal hyperplasia, the narrowing of the major aortic arch branches, also the carotids, right? And then we can see mononuclear cells, which are also seen around the vasa vasorum. What is vasa vasorum? The arteries or the vessels, which are basically supplying our thick arteries as well. Okay. So we have muscles there as well, and they also need perfusion. So these are the vessels which are providing it. Okay. Next, we can talk about some of the clinical features. So no pulse in upper extremity, visual loss, already explained, neurological abnormalities like syncope, for example, myocardial infarctions, because the coronary arteries may also be involved, and we can have pulmonary hypertension because pulmonary arteries may be involved, and elevated ESR. Great. Treatment, again, corticosteroids. Now, easy way to remember is granulomatous disease is that all large vessel, which are these two diseases, are both granulomatous inflammations. Okay. Now, next, you'll understand why I'm saying this, because the rest of the diseases, some can be granuloma, some can have no granuloma. It can be very difficult to remember. So remember, all large vasculitis are basically granulomatous. Next, medium vessel vasculitis. So here we have three diseases that we need to know. You can know two. I will mention the last one as well. It is not present, not in the presentation, but just know that it exists in case they ask you, in case that's their follow-up question. Okay. So we can talk about Kawasaki disease. First of all, who is it common in? It's common in basically Kawasaki is very important because this is the one that's present within children. So young Asian children who are less than 4 years old. What do we mean by medium vessel vasculitis? Which vessels are involved? These are basically muscular arteries, like the renal artery and celiac artery. So we're talking about Kawasaki's disease, right? So we said that we explained that it is present within children who are less than 4 years old. It's an acute arteritis of muscular arteries and can involve coronary arteries, which can be very lethal. Okay, if the coronary arteries are involved, it can be quite detrimental. Then, in this case, we can see that let's talk about why does this disease occur? Why do these children develop Kawasaki's disease? It's because of the anti-endothelial antibodies that basically develop within them. And we can also say that eventually they can actually lead to aneurysms and thrombosis or dissections, which can lead to sudden death. So if the professor asks you what is the most common reason that these children die of Kawasaki's disease, is normally due to these aneurysms which are forming, and then eventually it can basically lead to like rupturing of the aneurysms, which can actually lead to their death. Now, if we're talking about the clinical features, we can say that they have fever, very important to remember that they are febrile. Then they have conjunctivitis, erythema, erosions of the oral mucosa, strawberry tongue can be present. Important one is erythematous rash of the palms and soles. So if they have this kind of erythematous rash on their palms and soles, it has to be in our differential diagnosis. And then they also have lymphadenopathy. Treatment in this case, instead of corticosteroids, we're using aspirin. Now, before we say that, okay, we use aspirin, we already know that this disease can have very generalized symptoms as well, like fever, malaise, and people can actually suspect that it is viral infection. And in viral infection, never give aspirin, right? Because if we give aspirin, they develop Ray's syndrome. But in this case, if we give them aspirin, we can actually prevent the thrombus formation, and that is very helpful. Or we give them IVIG, which are basically these kind of like they fish for like those anti-endothelial antibodies that are present. So we can remove those anti-endothelial antibodies, and so that there will be no inflammation of the vessels, right? So this is Kawasaki's disease. Um, Okay, so this is everything you need to know for this disease. Next disease is polyarthritis nodosa. I know that as soon as you read this disease, you will remember the hepatitis B virus and the sketchy video. So it's good that if you remember that, because that can be one of the reasons why the patient may develop polyarthritis nodosa, and that can actually help us to actually diagnose it as well. Now, polyarthritis nodosa is actually a systemic disease. So it's present within kidney, heart, most of the organs. So it can involve most of the organs, but it does not involve the lungs. Please remember this. Exception is the lung. It does not involve the lungs, and it is commonly present within the kidney. Okay, who are the people who get this disease? Often in male adults. First male disease, okay? So this is mainly present within the adult in male adults. Next thing you need to know is the definition. It's a segmental, transmural, fibrinoid necrotizing inflammation. Okay. Okay. So it's a fibrinoid necrotizing of the whole wall. When we say transmural, we say that the whole wall is basically involved in this case, right? And morphology, very, very important. It has a string of pearl appearance. Okay. This is basically, if you say this, if you don't say this, it's a huge problem. Remember that this is the morphology. This is what they look like. And they can actually appear in three stages. We can have acute lesions, healing lesions, or healed lesions. In acute lesions, we see that it is fibrinoid necrosis and neutrophils. In healing lesions, we see fibroblast proliferation. And in healed lesions, we can see inflammatory infiltrate replaced by fibrosis, causing nodular appearance. So this is the reason why we have the nodular appearance with the loss of the internal elastic lamina. Now, do not think that all of the lesions that are present are in the same stage. They can be present in different stages. They can be present in various stages. Some may be acute, some may be chronic, and that's why the size of the nodules and the thickness of the nodules can actually vary. The clinical symptoms that we would see in polyarthritis nodosa is that they may have hypertension if it is present within the renal artery. They may develop abdominal pain with melena if the mesenteric artery is involved, confusion if it is neurological. Skin lesions may be seen, and obviously aneurysms and thrombosis may also be present. Initially, I already talked about the diagnosis that we have to do biopsy, but apart from biopsy, in this case, we can actually search for the hepatitis B virus antigens in the serum, and 30% of the patients actually we can see this. The third disease that I was talking about that I have not mentioned in this presentation, because if you know two diseases per vessel would be enough, but they can ask this disease as like a follow-up question just to know if you know it. So we have the Burger's disease, easy name to remember, mainly present in heavy male smokers who are less than 40 years old. It can be either an acute or chronic inflammation of medium-sized arteries, mainly involves the tibial and the radial arteries, and it has a very strong association with smoking. Okay. So in this case, the patient actually develops like Raynaud syndrome. So their tips get very cold. There's vasospasms, ischemia, ulcerations, and eventually we have to amputate the finger. So the classical presentation of this disease is that they eventually develop these ulcerations and gangrene. So we have to amputate the toe or finger. But they can also present with Raynaud syndrome, which basically means that initially as I already explained, cold, vasospasms, ischemia, ulceration, and autoamputation. Then, clinical features is that they can have severe pain, gangrene, Raynaud's phenomenon, which is vasospasm that leads to pallor and discoloration of the finger and toes, and thrombophlebitis as well. The finger in this case actually starts normal, but then it becomes white, then it becomes blue, and then it becomes red. Why does it become red? Because of the reperfusion. I previously in one of my videos, I actually talked about reperfusion injury, so you can actually go and look back at it. Okay. Finally, we can go into the small vessel vasculitis. Small vessel vasculitis has four diseases. So we have Wegener's granulomatosis. Who is it mainly present in? 40 to 60-year-old males. What is the definition of the disease? It is systemic necrotizing granulomatous disease. It presents with a classic triad. This is something that you really, really need to remember. So this is something that's a very classical feature of this disease. So it has like three things. We can see that it has these respiratory granulomas, which are non-caseating, and it spans from the nasopharynx to the lungs. You need to know this, nasopharynx to the lungs, and you'll understand why in the next disease. Then it has necrotizing vasculitis of small vessels, which are normally systemic, and they can lead to focal, segmental glomerulosclerosis, and eventually they can actually lead to these necrotizing crescent-shaped glomerulonephritis, and can actually lead to rapidly progressive glomerulonephritis with hematuria. There we can actually see like inflammatory cells that are present within the Bowman's capsule. So this can actually be very, very detrimental for the kidneys as well. For the diagnosis in Wegener's granulomatosis, we see C-ANCA. Now, apart from the biopsy, we can check for C-ANCA, which is basically a cytoplasmic anti-neutrophil cytoplasmic immunoglobulins, which are actually correlating with this disease. So if we see that they have C-ANCA, it can actually give us kind of like a definitive diagnosis that this may be a Wegener's granulomatosis. Apart from the biopsy, we do this. Now, a disease which is very similar to Wegener's granulomatosis can be microscopic polyangiitis. Now, microscopic polyangiitis is a segmental necrotizing vasculitis. It does not have granulomas. Okay, that's why it doesn't say necrotizing granulomatous disease. It is literally just a segmental necrotizing vasculitis, and it affects the lungs and the kidneys, but it does not involve the nasopharynx. In Wegener's granulomatosis, it has granuloma, it involves nasopharynx. In microscopic polyangiitis, no granuloma, no nasopharynx, but very similar to Wegener's granulomatosis. Okay. Another difference from Wegener's is that In this case, they don't have C ANCA, but they're positive for P ANCA. Okay. And the clinical features is that they will have lung, kidney, and skin involvement. Again, they can lead to necrotizing glomerulonephritis. In most, like 90% of the patients will have this. And we can also see a palpable purpura. Okay. I've also mentioned for Wegener's like a pneumonic, which is so we can say that it's a C disease because in the nasopharynx, lungs, and the kidney, they normally produce a granuloma, the respiratory granuloma, which is non-caseating. It's a kind of like a C shape. We can see C ANCA, which is elevated, and the treatment is corticosteroids or cyclophosphamide. Great. Now, next, we can move on to almost done. We have Churg-Strauss syndrome, which is normally an allergic disease, we say. And in this case, we say that, or it is also known as eosinophilic granulomatosis with polyangiitis. I remembered the other name, the eosinophilic granulomatosis with polyangiitis, because it just gives me the entire information of the disease. So I know I don't need to remember what disease it is because it is literally the definition. So it's systemic necrotizing granulomatous disease with eosinophils. That's the definition of the disease. It includes asthma, allergic rhinitis, atopic dermatitis, and necrotizing granulomatous vasculitis. So this is basically what we can see in the patient. Clinically, what would you see? Sinusitis, asthma, rhinitis, kidney failure. And in this disease, they have elevated P ANCA. So if you ask me the question, okay, how would we differentiate it from microscopic polyangiitis? Because both of them have P ANCA. The difference is that in Churg-Strauss disease, we can see granulomas and we can see eosinophils. In microcytic polyangiitis, we don't see granuloma. Okay, so they have no granuloma. Next, we can talk about Hinoch-Schönleins purpura. So this is actually a very different disease, or you can either remember this name, but I would suggest that you remember immunoglobulin A induced vasculitis. So this you can use the other name as well. So it's the other name is immunoglobulin A induced vasculitis. Okay. So this is the most common vasculitis in children, and it is normally following like urinary tract infections. So it's normally occurring because of the IgA antibodies that are present. So what happens is that we have these IgA immune complexes, which will basically deposit into the vessels and will basically lead to vasculitis. In this case, they normally prevent with like a palpable purpura, not mainly within the lower limbs. We can see arthropathy because the immune complexes can deposit within the joints and can lead to pain and swelling. We can see gastrointestinal pain and bleeding and also glomerulonephritis because we can have IgA nephropathy that can also be present. Okay. So this is basically everything you need to know. These are all the diseases. So this is basically like a summary that is present, right? So it's like it's easier to remember because we have 2 large vessel diseases, we have 3 medium vessel diseases, 4 small vessel diseases. I'm sure you can read it on yourself by yourself, but this is basically a very, very good like summary of everything, what diseases are granuloma, which are basically producing granuloma, which are without granuloma, who are P ANCA, C ANCA, what are ANCAs basically, and yeah, so these are basically everything that you need to know and what antibodies are present. How can we detect the particular disease? And I hope it was helpful and all the best. Thank you.